Kia ora koutou, everybody. Welcome to our lunchtime webinar, which is provided today in partnership with He Aotearoa. And the topic today is what's new in type 2 diabetes care in 2021. Your speaker today is Dr. Ryan Paul. He's an executive member of the New Zealand Society for the Study of Diabetes. And Dr. Paul recently led the development of the NZSSD guidance on the management of type 2 diabetes in New Zealand, and is heavily involved in teaching primary care clinicians, diabetes nurse prescribers, and endocrinology trainees. Thank you and welcome, Ryan.
No, thank you. And welcome to everybody. I'm glad there's so much interest in this. It is something I'm passionate about, and you hopefully be aware of the new NZSSD guidance that came out for the management in type 2 diabetes. I will share that website with you at the end if you haven't seen it or been aware of it. And I'm really going to focus on the key points from that guidance in terms of what may be different for you in primary care. And today's talk's going to focus very much on the new agents, the SGLT2 inhibitors and GLP-1 receptor agonists that become available. I will warn you, it's quite similar to my presentation I gave the other night for the Good Fellow Symposium, but it's a lot more in depth than that. So I thought we'd start off with a case, and that is Mrs. T. Just to get you thinking from a clinical perspective. She's a 58-year-old Samoan woman, long-standing type 2 diabetes with a background of ischemic heart disease and diabetic renal disease. And HbA1c is not too bad at 56 millimole per mole. Their blood pressure is fairly good as well, 112 on 76. And you can see here it's a regimen, which is quite a typical, I guess, of our current regimen that we've got available. She's on metformin and vildagliptin, glipizide, decent dose of Lantus, and a number of antihypertensives. And she hears that there are new treatments for diabetes in Māori and Pacific people. So she asks you, how do they work? Should she be on them? And what side effects do they have? So let's think about how would you come from that from a clinical perspective. Just as a wee bit of introduction. So SGLT2 inhibitors and GLP-1 receptor agonists are the new classes of glucose-lowering medications that we have available. It's just become funded from the 1st of February. I do stress new because, they have been used in other parts of the world since 2005. So it's long-standing, I guess, internationally. It's great that they're finally here, as it does going to change management of diabetes on its head. And the reason, I guess, why we're so excited about them is that they reduce glucose levels by novel mechanisms, so up and above all the other glucose lowering therapies that you have, and they all work together in synergy, and they don't cause hypoglycemia by themselves, and they don't cause weight gain. In fact, they cause weight loss. So all of a sudden you can see there's much bigger advantage than other agents. But on top of that, and I guess one thing that excites people the most is that they reduce mortality from cardiovascular disease and renal disease up and above their effects on glycemic control. And in particular for renal disease, which is such a big issue for our Māori and Pacific patients, we think they are 4 or 5 times more likely to have diabetic renal disease than Europeans. SGLT2 inhibitors are the first, and GLP-1 receptor agonists are the first agents since ACE inhibitors that we have to slow down the progression. So it's been a long time coming. You're familiar with the name, so empagliflozin is the SGLT2 inhibitor that which will be funded, and gelaglutide will be the GLP-1 receptor agonist which will be funded. Now, I'm only going to focus this talk primarily on empagliflozin. That's because gelaglutide is not currently approved by MedSafe and won't be likely until the second half of this year. And I'm more than happy to do another talk down the track when gelaglutide becomes available. But I guess why it's important for all of us that manage our patients with diabetes is that at least a third of your patients will meet the funding criteria. In fact, in those practices with a high Māori or Pacific people population, that may be at least half. So it really is going to affect all of us in primary care. So how do they work, SGLT2 inhibitors? Well, it seems like a bit of an oxymoron, but when you've got type 2 diabetes, even though you've got hyperglycemia, you're reabsorbing pretty much all of the glucose that goes into the urine. So we know that about 90% of glucose is reabsorbed by the SGLT2 inhibitor in the proximal tubule. The other 10% is SGLT1. So sometimes you get dual inhibitors, but the main one here is just SGLT2. So in that, when you've got that in type 2 diabetes, it's overexpressed, you're absorbing a lot more glucose, you're absorbing a lot more water and sodium that goes with that. And as a result, you get hyperglycemia, you get increased fluid, which then leads to problems with basically the complications with the renal disease and heart disease. So how inhibitors just work, and so I tell patients, they make you pee out glucose and salt. And with that, you get fluid loss as well. So you get reduced blood glucose levels. It's important that it's independent of insulin. So it doesn't cause hypoglycemia. And more than that, you actually get reduced insulin levels as a result, which helps with weight loss. You also get the reduction in the circulating fluid volume, which helps with regards to cardiovascular disease, and also restores normal tubular feedback in the kidneys. And I'll show you a picture or pictorial of that. And SGLT2 inhibitors may work through other mechanisms, which we can talk about in Q&A time if you'd like to. So here's just a pictorial, and you're more than welcome to go back to the slides and watch the recordings. But when you've got the diabetic kidney, basically you've got too much fluid going through, you've got the hyperfiltration, you've got the increased reabsorption of sodium and glucose in the proximal tubule, which basically takes away the pressure and sodium at the macula densa. So the kidney goes into overdrive, it's trying to overcompensate, and which just makes the whole cycle worse. With SGLT2 inhibitors, you basically improve the supply of sodium and glucose to the macula densa, and as a result, you get constriction of the afferent arteriole and normalize the glomerular filtration rate. You normalize that pressure inside the glomerulus. I know it's a lot of technical speak, but the exciting thing is that SGLT2 inhibitors work on the afferent arteriole, ACE inhibitors work on the efferent arteriole. So the two together, they work additively to basically protect the kidney from diabetic renal disease. So it's important to think, I'm still going to use both agents in diabetic renal disease. So going through the benefits, so the reduction in glucose levels are only modest. We're still looking at a reduction about 5 to 11 millimole per mole on an average. So that is probably more, it's more so than vildagliptin. It's probably not much as metformin. But the one thing that SGLT2 inhibitors do is they help you lose weight. So average about 1 to 3 kilograms at 2 years. There's also a modest reduction in blood pressure by itself. Probably realistic about 3 to 4 millimeters of mercury mean. So when it comes around, it's important when we think about starting the medication, which I'll discuss in the next few slides. The other, I guess, big benefit is the reduced progression of diabetic renal disease. So that stops the progression to dialysis and death from renal disease. And as I mentioned before, it's additive to those ACE inhibitors or ARBs, or angiotensin receptor blockers. With that, it's you're probably looking, if you look at NNT or numbers needed to treat, you're looking at probably if you treat 25 patients with type 2 diabetes for 5 years, you prevent one person progressing on to end-stage renal failure. So that's, those numbers, and I'll go on the next slide to show the other benefits, but that really is, I guess, relatively low numbers compared to other treatments we have. There's also the benefit of reduced cardiovascular events, and once again, that's about the number needed to treat of about 20, and that's only primarily myocardial infarction or heart attacks and death. SGLT2 inhibitors haven't been shown to produce non-fatal stroke, but they do reduce death from stroke, and that might influence your choice of whether you go for empagliflozin or gelaglutide. And once again, I'm more than happy to ask questions about that. It's probably something that will come out in a webinar later in the year. SGLT2 inhibitors are also great for heart failure. In fact, you get cardiologists and renal physicians arguing that they're actually their drug and not that to treat diabetes. But empagliflozin will prevent heart failure, and it will also reduce basically exacerbations of heart failure and death from heart failure. And with all these benefits, we get reduced mortality. What I'll do, one point I do want to stress is a good time to do it. is, I guess the reason why we're excited is that these benefits came from studies which weren't actually designed or powered to detect these benefits. Some of you may remember when rosiglitazone came out about 15 to 20 years ago, unfortunately it led to an increased rate of MI from dyslipidemia. So the FDA in the States basically said, if you're going to bring out a new diabetes drug, you need to prove that it's safe. So all these benefits are based on those safety studies of thousands of patients, which then led to, hey, there's actually a benefit here. So one thing that I will say is that the evidence at this stage is only confined to those with non-renal disease or known cardiovascular disease. So we're only talking about secondary prevention. There's no evidence to date that SGLT2 or empagliflozin is beneficial in primary prevention, i.e. preventing diabetic renal disease and cardiovascular disease. It may well do, but we're still waiting for those studies to come out. There's also no evidence that SGLT2 inhibitors are more or less effective in Māori or Pacific peoples. So I think that's important to know when we come to the special authority funding criteria. It's great that pharma can put that in there to reduce the barrier to access, but does not mean to say that these medications will be any more effective in Māori or Pacific people. But what is important is we know that Māori and Pacific people are so disproportionately affected by renal disease that they are a group that will likely benefit from their use. So no drug comes without side effects, unfortunately. And the main side effects of empagliflozin is basically coming from peeing out glucose and fluid. So some patients do complain of polyuria or increased frequency of going to the toilet. Typically, it's very transient and mild to moderate intensity only. Sometimes the patients with prostatic disease are those that notice it the most, just because of the nature of their underlying history already, and it does not typically stop treatment or lead to nocturia over polyuria during the day. One adverse effect it is careful to be aware of and careful of, though, is volume depletion and hypotension. So the greatest risk is in those over 75, particularly over 85 years of age. So I would be very cautious using empagliflozin those over the age of 85, particularly if they're on diuretics and ACE inhibitors or ARBs already. It can be associated with a transient decrease in eGFR, very similar to what you can get with the ACE inhibitors. That does bounce back. And if their blood pressure is tight beforehand, and I'll come around to some numbers around that, you may definitely want to think about reducing the other diuretics and antihypertensives that they're on if you're going to start empagliflozin. The other common adverse effect is the increased risk of genitourinary infections. So that's both UTIs and mycotic infections such as thrush or bronchitis in men. Now, these are a lot more common in women, and discussing good genital hygiene is important. They're very rarely associated with significant infections such as pyelonephritis. There is one infection that's important to be aware of, and that's Fournier's gangrene. It's really rare. Most of it, I've never seen it. I don't think many people have seen it at all in New Zealand. And that's when you get necrotizing fasciitis of the perineum. So it can be a very nasty infection. The time to suspect it is when you've got a patient that has very significant genital or perineal pain that might be out of keeping with the redness or swelling or fever. So is it an infection? It's when you think about, I guess, necrotizing cellulitis or infections elsewhere. But there have only been a few case reports in tens of millions of users of SGLT2 inhibitors. So just to put it in perspective, I doubt we'll see one in New Zealand. It's important to be aware that SGLT2 inhibitors will only cause hypoglycemia if they're used together with insulin and sulfonylureas. So if I've got a patient that's on metformin and vildagliptin, for example, and I add in empagliflozin, I don't actually bother getting to check their glucose levels unless they're unwell. But if they are on insulin or sulfonylureas and they've got tight control, and you may get a guide to that from their glucose levels or from their HbA1c, for example, it's less than 64 millimole per mole, you may be thinking, hey, I'm just going to cut back to try and prevent hypos from occurring. And a rough or good ballpark starting figure is halving the dose of insulin. That might be both basal and prandial insulin. And also, halving the dose of sulfonylureas and reducing the dose of insulin by about 15 and 20%. And that's both the basal and prandial insulin. That might be an overshoot in many people, and you can rapidly put them back up to their normal doses. If someone's got an HbA1c over 70 to 75 millimole per mole, I don't change anything. I know that's realistically, they're not going to cause hypo, just I'm adding another agent. And for lots of our patients that meet the criteria, you won't need to change any of the other glucose lowering medications. The other, I guess, side effect there's been a lot of hype about, I know a lot of people are worried about, is the risk of diabetic ketoacidosis, or DKA. And that includes DKA when glucose levels may be normal, only slightly high. And that's got the term normoglycemic DKA or euglycemic DKA. Now, it is rare. I want to stress it's 1 in 3,000 patients, but it is something that people should be aware of. So we advise patients to stop the SGLT2 inhibitor, stop the empagliflozin whenever they're unwell, or 2 days before surgery or any elective procedure. And then they can restart their empagliflozin once they're well again. We also recommend that if patients have symptoms of DKA, and the most common one to be nausea, vomiting, or abdominal pain, that it's important they get their capillary ketone levels checked. Now, this will be, I guess, is an issue because unfortunately, Pharmac have said they won't fund ketone meters for these patients. I know a lot of pharmacists are encouraging patients on SGLT inhibitors to purchase the CareSense dual meter, which costs, I think, roughly about $30 to $40. But for the bulk of patients, it would be, I guess, unrealistic. So we are recommending, I guess, patients, it's either going to be going to practice. So it's thinking about how at your practice, we at least make sure that these patients have their ketone levels checked, or do these patients need to attend hospital to have their ketone levels checked? And if they're above 1.5 millimole per litre, then it's important to exclude DKA, and that by doing a venous gas and going off there. So they need to go to hospital, basically, if their ketones are high. And because of the risk of DKA, we don't recommend using empagliflozin in the following groups. So if you've got type 1 diabetes, I would definitely not be prescribing this unless you've got specialist approval. I've only got a handful of patients that I use SGLT2 inhibitors with type 1, and it is off-label at present, but it's likely beneficial, but I would be stressing not to use it without speaking to secondary care first. If your patients have previous DKA, and DKA can happen in all types of diabetes, just not type 1 diabetes, that's important to think of. And the other biggie is if someone's on a low carbohydrate diet, and or if they drink a lot of alcohol, because both of those will increase ketones. And I guess the reason why those ketones can go higher is SGLT2 inhibitors actually switch your energy source. They make you use fat over carbohydrates. It's one of the reasons why it leads to weight loss. So it's thinking about in what patients, if I make ketones worse, I run the risk of DKA. We can talk about that in the Q&A session as well. So when should they be used? Because the other take-home message from today is best practice is slightly different to the funding criteria. So it is important to realise, hey, when should I be offering these patients to self-fund? And we can go about that in more detail as well. So for all patients, lifestyle management and metformin remain first-line management. And that's right from diagnosis. Even if you've got a patient that's had type 2 diabetes for 20 years, should still be thinking about that it should be on metformin. And the reasons for that are mainly that metformin does reduce your risk of cardiovascular disease up and above glycemic control. So we know that it's beneficial. We know that in all these, pretty much all studies of empagliflozin and other SGLT2 inhibitors, all the patients are already on metformin. Now, the patients which really benefit from empagliflozin, and this is where the special authority funding criteria benefit does identify them well, is it's basically it's all your patients with type 2 diabetes. If they've got any evidence of renal disease, and that may be microalbuminuria and or low EGFR, or heart failure, or non-cardiovascular disease, and that's any cardiovascular, peripheral vascular, or cerebrovascular disease, and or a very high 5-year cardiovascular risk, and we classify high as more than 15%, and that's using your calculators, and that is irrespective of the patient's glycemic control and other glucose lowering therapies. So it doesn't matter if their HbA1c is in the 40s, these patients will benefit from SGLT2 inhibitors. They will end up reducing complications and saving lives. And it doesn't matter if these patients are on insulin, for example, or any other glucose lowering therapy, they'll benefit from an SGLT2 inhibitor. The other group which would benefit from empagliflozin, so in those without renal disease or cardiovascular disease, the main group we're targeting is all those with an HbA1c above target. So that's more than 53 millimole per mole in most patients, or if they're and if they're overweight or obese. Now, the funding criteria doesn't cover this, and I'll go through this in more detail. I think the next slide. But we know that empagliflozin will lead to weight loss, whereas vildagliptin's weight neutral, and pioglitazone, sulfonylureas, and insulin lead to weight gain. So that's the big reason there. But vildagliptin is still a very good second-line agent. In fact, vildagliptin's the only current second-line agent that we know of, because the studies haven't been done for others. But in combination with metformin, will actually slow the progression to needing insulin therapy. And at present, that's vildagliptin's the only agent that's been shown to use that. So it is still very, very beneficial. Now, the cost of funding empagliflozin or the other SGLT2 inhibitor available in New Zealand's dapagliflozin, that's not funded at all under any criteria, is approximately $85 per month. I've been really surprised in my practice in terms of discuss with patients about the cost and how many people will actually take this up. So I think it's important just not to assume that patients cannot afford it, but at least putting it out there and having that discussion, because the thought of not going on insulin or particularly reducing renal disease or heart disease is a big carrot for those that do have the financial capabilities. I will say it's important to encourage your patients to shop around, just because pharmacies do have different markups. Some can be even in the vicinity of $15, $20, $30 per month. So I will say the online pharmacies like Zoom or Pharmacy Direct are often some of the cheapest. So do get your patients to shop around. So when shouldn't empagliflozin be used? These are the, I guess, pregnancy, breastfeeding, and children under the age of 18 years. There's no safety data. So we do not recommend using in those groups at all. There's also no real safety data for those with end-stage renal failure with eGFR less than 30 mils per minute. Now, one thing that is important to realize about empagliflozin is that when basically the worse the renal function, the less glucose lowering effect you're going to have. In fact, you may find that someone with an eGFR of 40 mil per minute, you may find you're only reducing glucose levels by a fraction, but in those patients, they'll still get the benefit from reduced renal and cardiovascular disease. So even though their glucose levels aren't going down, they're still benefiting from it. So that's an important thing to remember. And then you worry about patients which are high risk for adverse effects. So you've got those that may have had previous severe or recurrent genitourinary infections. You've got those which are high risk for DKA that we've discussed, and high risk for volume depletion. The other group is those with recurrent renal calculi. And that stems probably from the potential risk of dehydration, but also the SGLT2 inhibitors lead to increased urinary excretion of uric acid, which is very exciting in that they will likely reduce gout as well in our patients with type 2 diabetes, which is often a common comorbidity. Now, there's no, the studies haven't come out to conclusively show that, but it does look like a potentially beneficial effect of SGLT2 inhibitors as well. So here's the special authority criteria. This is something that's really important for you to remember, because you'd be thinking, here's about 40% of my patients, do they get funding? So it's basically all those patients with type 2 diabetes. So I will say empagliflozin is not funded for any other type of diabetes. Okay, it's just those with type 2. With an HbA1c above 53 millimole per mole And it's despite 3 months of regular use of any glucose-lowering therapy. Generally, that's metformin, but can be anything. It can be vildagliptin, sulfonylurea, or insulin. And they can't be on a funded, or they can't be on funded dulaglutide at the same time as empagliflozin. Now, that's not going to matter now. Dulaglutide's not improved. So even in those patients which you may think, hey, they may benefit from dulaglutide more than empagliflozin, I'll be putting them all on empagliflozin now. So they've got at least a few months of benefit without waiting. So in addition to all of those, they must have one of the following criteria. Must be either Māori or Pacific ethnicity, have evidence of diabetic renal disease or cardiovascular disease, or very high cardiovascular risk, or a high lifetime CVD risk due to onset of diabetes in childhood or as a young adult. Now, the reason why that caveat is put in there is that you'll find that pretty much all of your patients under 40 years of age will have a low 5-year risk when you do on the risk calculators, basically because of the primary of the age. They may still die in 10 to 15 years time from cardiovascular disease, but their cardiovascular risk at that point will be low. So they're a very high risk group, important risk to target. So if you've got any of those criteria, then you can go forward and do the funding for empagliflozin. Now, the patient groups which would still be recommending best practice in, but don't meet the special authority funding criteria, are those that we do know have renal disease or cardiovascular disease, and the HbA1c is already to target. So the HbA1c will be less than 53 millimole per mole. We know that these patients will still benefit, so it's worth having that discussion with them. Similarly, for on dulaglutide already, both dulaglutide and empagliflozin can be used together. In fact, they have additive effects to each other. We'd be recommending it clinically, but unfortunately, we don't have the funds in the country to currently fund dual use at present. So that's one area we'd have that discussion about self-funding. And all those patients which are non-Māori, non-Pacific ethnicity with an HbA1c above target despite metformin plus or minus vildagliptin. Okay, particularly those that are overweight or obese. This is the other group to be really talking about self-funding in. So in terms, how do you start it? Well, you may be familiar with what tablets that are out there. So there's empagliflozin alone, or Jardiance is its other name. It's available in 10 milligram or 25 milligram tablets. And then you've got Jardiamet, which is basically empagliflozin in combination with metformin. You can see there that the various strengths that are available. So when you're starting empagliflozin, you're starting 10 milligrams once a day. Or if you're starting Jardiamet, it's the 5 milligrams and the combination of metformin, that's twice a day. Now, I try to combine with metformin if I can, just to reduce the number of tablets, but that's depending on whether you can get the dose of metformin that you want to get, if it's in those available combinations. If they're already on, but they may already be on Galvimet, for example, and already in the combination, go straight for empagliflozin. So I will stress that it's important to keep going on the metformin. It's also really important to always be talking about ongoing sort of lifestyle management. They are the cornerstones of management of type 2 diabetes. And we've sort of already discussed that you may also be thinking about reducing diuretics and antihypertensives, and sulfonylureas and insulins are required. And we'll come back to our case. Our case was designed to be a good example of that. The other thing which is really useful to do when you're starting empagliflozin is providing advice on sick day management and when do they need to get their capillary ketone levels checked. So the Jardiance book's very good. I know that Bo Ringer are currently trying to make sure that's in other languages such as Māori, Tongan and Samoan, and there will be a separate Jardiamet book coming out. But one thing we're trying to do as the New Zealand Society of Diabetes is coming out with a sick day management plan that you can print off for every patient in the country, which would be something be a very useful resource. But you want to be discussing the adverse effects and advice on sick day management when you're starting. Pharmacists are also very good at handing out the patient information if you don't have it. And then it's about making sure these patients are reviewed. And I think it'd be reasonable to ensure that you're reviewing them at sort of maximum 3 months, and you can repeat the blood pressure, HbA1c and EGFR at that time. Now, if their HbA1c is above target, you can increase the 25 milligrams once daily. So daily tablets. That may be the 25 milligrams alone of empagliflozin, or maybe the 12.5 milligram tablets twice daily in combination with metformin. And you can obviously review your patients at any time. I sort of ask them, let me know if you're having trouble, come back earlier, particularly if hypoglycemia is occurring, if on insulin and sulfonylureas at the same stage. But it's just making sure you've got that regular review in place. So if we go back to our case, and I'm hoping to save plenty of time for questions and answers as well after the talk. So we really want to remember she's a very good candidate for empagliflozin because of her ischemic heart disease and diabetic renal disease and being overweight as well. So she's the perfect candidate. And you think, what am I going to do in terms of when I start the empagliflozin to other medications? And we know that, like you can see enlisted there, but she is on glipizide and Lantus. There is a risk of hypoglycemia, and her blood pressure is pretty decent, and she's on Acupril, Flodipine, and Furosemide. So just want to have a think about, well, what would I do to actually change her medications? This is what I do. There's no perfect answer here, but this is what I do. And that is remembering that metformin, you do have to adjust the dose of metformin in renal impairment. Above that, there's actually no benefit in metformin doses above 2 grams per day. So I never go above 2 grams per day prescribing metformin. And when you get doses above that, you're just really going to cause the gastrointestinal side effects. So you're going to, for her, you're going to reduce down to 500 milligrams twice a day metformin, which is the maximum dose for her renal function. You're going to keep the vildagliptin going. You've halved her glipizide, and you've reduced her Lantus back. And that's to try and help reduce that risk of hypoglycemia. And I'll explain why I've cut back to 50 units later in the talk. You've kept going with the Acupril, but you've stopped her Flodipine. Now, the reason why I've done it this way around is that if you've got someone with diabetic renal disease, you really want to keep the ACE inhibitor or angiotensin receptor blocker going if you can. The benefits are additive to those with SGLT2 inhibitors, whereas any other antihypertensive agent does not reduce renal disease up and above its effect on the blood pressure. So you're trying to prioritize which antihypertensive you use. Also halved her furosemide as well. Now, this, when you change your diuretics, it's really going to depend on their fluid state. But in someone that's pretty well controlled, for example, on 40 milligrams a day of furosemide, I may consider stopping it. If they're on 80 milligrams, I reduce it down to 40. And if they're on larger doses, you may think about halving it. But a lot does depend on the fluid state. You can't give a blanket answer to everyone. You also discuss the importance of genital hygiene and provide sick day management and organise to review her in 3 months. At this time, her HbA1c is 58, but she's having no hypos, and her blood pressure is 135 on 88 with an LDL of 3.2 millimole per litre. So let's think about, how would you optimise her management now? And actually, how often should you repeat her HbA1c? Because I always get asked this question as well. So you increase, HbA1c is above target, so you increase the empagliflozin to 25 milligrams daily, and you organise another HbA1c in 3 months. So we do recommend, basically, everyone that's not to target, and HbA1c target's individualised, but for most patients it's less than 53, that you're doing the HbA1c every 3 months. Once the HbA1c is to target, we then recommend every 6 months. And for her, the changes made to her medication this time is that we've increased her Acupril to try and get her blood pressure to target, and we can talk about that. And you've started the atorvastatin basically to try and reduce the LDL and reduce the cardiovascular risk. And you've been able to stop her furosemide as a result. So she brings along her son to the next appointment, and Mr. T is 28 years of age, is BMI of 38, and HbA1c of 75 millimole per mole despite lifestyle management. And how would you manage his type 2 diabetes? Just thinking about, he's a new patient. Well, for him, you're still going to go over lifestyle management again, and you're going to start metformin. Now, when I start metformin, one of my bugbears is that patients get labelled as being intolerant of metformin, And what's happened is that they've been started on a high dose, got the side effects, and basically got the side effects as a result. Most of these patients will actually tolerate metformin well if they start at a lower dose, or basically a very low dose, and increase that up slowly. Now, unfortunately, we don't have the extended release metformin available in New Zealand, but I tend to, some patients I know that at risk for side effects, I start at 250 milligrams once a day and slowly build that up over the upcoming weeks. This is very much an anecdotal story, but I will say that when metformin's in combination with other tablets, and that includes Galvimet and Jardiamet, that patients tend to tolerate a lot better than when metformin is by itself. So you may find that actually just switching to a combination tablet is beneficial. Now here is a patient, and the other thing I want to stress is about reducing clinical inertia, because clinical inertia is probably the biggest barrier that we've got in diabetes care. And if I know that someone's got an HbA1c of 75, they're very, very unlikely to get down to target on metformin alone. In fact, basically the mean maximal reduction in HbA1c metformin is about 16 millimole per mole. So all of a sudden, you know that you're going to need a second agent. For someone like this, that should benefit from empagliflozin or a GLP-1 receptor agonist, I'll discuss that first about self-funding, because unfortunately, they won't qualify for funding until they've been on metformin or another agent for at least 3 months. But in this guy, he couldn't afford empagliflozin to fund it, so you'd start Galvimet initially and then switch to empagliflozin in 3 months if his HbA1c was above target. So it's also thinking about how can I go treat these patients hard and early. So I guess, briefly touched on these learning points from this, but I know there's still a wee bit of a hangover in primary care, and a lot of it comes back from reporting to the ministry that the target's HbA1c is 64 millimole per mole, and most patients it's less than 53 millimole per mole. You may relax it in terms of if there's a risk of hypoglycemia, or you may actually even be more aggressive if they're young. You may even go for less than 48 millimole per mole. It's important that you individualize that and then repeat the HbA1c frequently. Spoken about the benefits of metformin and the mean maximal reduction. Now here's something that may be new to a lot of you, and particularly will change a lot of what we do in primary care. But it's one common approach is just increasing the dose of basal insulin up and up and up, trying to get good glycemic control. Now we know that doses of basal insulin over 0.5 units per kilogram per day typically do not reduce glucose levels any further, but do lead to weight gain. So we'll recommend, if you're increasing the dose of the basal insulin, which is usually Lantus, that you stop at 0.5 units per kilogram, and that's when you add in prandial insulin. And that may be either with premixed or bolus insulin, but that's the point. You're not just going to keep increasing the Lantus up to ridiculous doses. The other, I guess, big change is we're turning the treatment algorithm for type 2 diabetes on its head. So I want you all to think about, I guess for the last 20, 30 years, we've treated based on glycemic control. So we've added in stepwise agents based on, is the HbA1c too high? Now what we're doing is we're treating based on cardiovascular and renal benefits. So every patient's going to be on metformin. They'll then be on, if they've got diabetic renal disease or cardiovascular disease, either on an SGLT2 inhibitor or GLP-1 agonist on both. And vildagliptin will be an alternative in that group, was weight neutral. We used to use sulfonylureas a lot. They are now gone to at least third or fourth line agents, and that's because of the potential for weight gain and hypoglycemia. If you start a patient on glucoside or glipizide, they're going to also have to start monitoring their glucose levels as well. So it's nice to avoid it if you can. And the big point is sulfonylureas don't reduce cardiovascular and renal disease up and above their effects on glycemic control. Management of hypertension remains as important as ever. So reducing high blood pressure is probably as important, if not more important, in reducing all your microvascular and macrovascular complications of diabetes. So our target blood pressures, these haven't changed in the guidance. These are still less than 130 on 80 millimeters of mercury if you've got complications of high cardiovascular risk, or less than 140 on 90 millimeters of mercury if very, very low risk. You may even choose to be more aggressive in those patients with non-complications, but you might aim for less than 125 on 75 millimeters of mercury, but I wouldn't go gung-ho. We know that aiming for very aggressive management of high blood pressure probably does more harm than good. Now, treating someone with hypertension with diabetes is slightly different than without diabetes. Basically, if they've got renal disease, you want to maximize the dose of your ACE inhibitor or angiotensin receptor blocker before you add another agent. So you really just increasing that one agent up, and then you're switching. Now, the other, I guess, point that you may not be aware of is that ACE inhibitors or ARBs only reduce renal disease in those that have pre-existing renal disease. So they do not prevent renal disease. So if you've got someone with diabetes with no evidence of diabetic renal disease, it's fine to use any agent. You may still choose to use ACE inhibitors or ARBs, but using a thiazide or calcium channel blocker, for example, is just as satisfactory. Management of dyslipidemia also remains critically important, and we're aiming for LDL cholesterol basically less than 1.8 millimole per litre. I know the cardiologists would like it lower, but that's the target at present, and that's basically in all those patients with known cardiovascular disease or renal disease or high cardiovascular risk. The other group which you may be talking about starting statins in is those young people who are very high risk of lifetime cardiovascular disease, but low risk on the calculators because of their age. Another take-home message is that I hardly use aspirin for primary prevention in type 2 diabetes or any form of diabetes at all. That's because we know in patients with diabetes, aspirin is less effective for primary prevention, but the risk of bleeding is increased compared to Joe Bloggs. So you'd only now consider aspirin if the very, very high cardiovascular risk with a low risk of bleeding. But I find I stop a lot more aspirin than I start in this group. You still want aspirin for patients with secondary prevention, but for primary prevention, it's completely changed. So here's another case, just to also talk about, I guess, new aspects from the guidance that you may not be aware of. So this is Mr. C. He's a 16-year-old New Zealand European with a BMI of 31. And he attends basically an appointment for renewal of his Roaccutane for treatment of his acne. And he asks when he should be screened for diabetes, as he found out his brother just developed type 2 diabetes at 22 years of age. And it's what do you tell him? Because based on our previous cardiovascular risk, you probably, or recommendations for screening, you'd be waiting to approximately 45. Now his HbA1c was 95 millimole per mole on when you do the blood test. Does he have diabetes? And when and how do you confirm the diagnosis? So this may be a common part in your practice, is thinking, how long do I wait before we do second testing? So you get him back after you get phoned about the HbA1c result, and you hear he's lost 12 kilograms of weight unintentionally over the past 3 months with some polyuria and polydipsia. You prick his finger at the practice and it's 15 millimole per litre. Just thinking about what type of diabetes does he have and how do you treat him? Just go through it. So we're now recommending all adults with, and that will be above the age of, well, when we say adults, typically for adult services in New Zealand, it's above 15 years of age. Our pediatric colleagues would say this fits for all patients greater than 10 years of age. Okay, so this is a whole new group which we're recommending screening for diabetes in. And we reckon they should at least have an HbA1c performed if they have 2 or more risk factors. It includes obesity, non-European ethnicity, particularly our Māori and Pacific peoples. If they've got a family history, they've got clinical features of insulin resistance, or they've got very high risk factors such as long-term corticosteroid or antipsychotic therapy. We've still got patients with antipsychotics which die about 25 years earlier than their peers, and it's not from suicide, it's often from metabolic disease. They're a really important group to target. And then you're performing that at least every 3 years. And I know this is a big change, but I guarantee you're going to pick up a lot more patients with diabetes. Then if you get an abnormal test, you're then confirming the diagnosis of diabetes as soon as possible. You may choose to do that with a repeat HbA1c, just to ensure it wasn't laboratory error, or you're doing a fasting glucose or a random glucose as soon as possible. And you may choose to do that in clinic or in practice, in your practice the same day. Next day, you're not going to wait the 3 months. So in that 3 months, basically all you're doing is just prolonging treatment, and the patient comes to harm. And then you've got the definitions there for diabetes haven't changed at all. One thing to realise is that everywhere else in the world, diabetes is an HbA1c greater than 48 millimole per mole. In New Zealand, we chose 50 millimole per mole for reasons I won't discuss, but don't be surprised if we align with the rest of the world at some stage in the near future. Differentiate between the types of diabetes, I think it's the hardest part of my job. That is because type 1 diabetes can occur at any age. I saw in hospital last week someone that was 90 that developed type 1 diabetes for the first time. So it's just not young people, it's just not thin people. With the increasing obesity of the general population, there's plenty of patients with type 1 diabetes that are obese at diagnosis. And what basically tests which can be really useful is your diabetic autoantibodies, such as your anti-GAD, anti-IL-2, anti-zinc T8 antibodies, and your C-peptide. You may choose to do that either fasting. I tend to do it after meals because you're basically stressing the pancreas. And if your C-peptide's less than 600 and your glucose is greater than 8, start thinking about type 1 diabetes. Positive ketones is the other thing which may give it away. And it doesn't matter what form of diabetes you've got. If you've got symptoms of insulin deficiency, the patient needs insulin. It's as simple as that. And we're going back to weight-based dosing, and that's 0.2 units per kilogram at night for most individuals, or 0.1 if you think they're very high risk of hypoglycemia, such as those with elderly or renal liver disease. The other thing which we're pushing is introducing insulin early. So you know if someone's got an HbA1c greater than 90 millimole per mole, that they're very unlikely to reach target on lifestyle management or the oral agents alone. It's about thinking about insulin early for these individuals. And then if you've got someone on basal insulin, you're then increasing the dose by 10%. If you've got 3 fasting levels greater than 7, until either hypos occur or the doses reach 0.5 units per kilogram per day, and that's when you're introducing prandial insulin. So we're just summarising, I guess going back to really about SGLT2 inhibitors. So empagliflozin, you should really be thinking about it. All your patients are type 2 diabetes with known renal disease or cardiovascular disease or high cardiovascular risk. And that's regardless of everything else, okay? These are the patient groups which are going to benefit the most. It's also important about thinking of those where self-funding may be appropriate. If you're worried about the risk of hypoglycemia, if they're on insulin sulfonylureas, you consider reducing those agents when you start. If they're not on insulin sulfonylureas, I keep everything else going. There's no need to change anything. You also want to think about, do you need to reduce the antihypertensives and diuretics before starting empagliflozin? But once again, if their blood pressure's high, or it may be above 140 millimeters systolic, I don't bother changing any antihypertensives. Sometimes I think about reducing the furosemide, but that's once again depending on the fluid state. But your reduction in blood pressure is only minimal with empagliflozin. And then you're really just going to make sure that your patients are aware of the adverse effects and have that sick day management plan in place. It's also thinking about in your practice, how can I have set up so we can measure capillary ketones in these patients? And when do I need to refer patients to hospital? And just like any other medication, if a patient's got adverse effects, you're better off stopping it if it's doing more harm than you're good. So here's the information on the guidance, and it contains a lot more information on empagliflozin as well as all the other medications for treatment of type 2 diabetes. It's the website address there. The guidance is live, and we'll update it basically as evidence changes, as access to interventions such as the funding criteria changes. We'll update the website. So the aims, sort of mentioned about these, but I think reducing clinical inertia is a big one, and so is shifting from glycemic control to think about how do I manage cardiovascular and renal disease. Okay, so you think about the patient as a whole. It's just not glucose, how do I reduce their blood pressure, lipids, and obviously don't forget about smoking cessation as well. It's got evidence on how to use the new agents, as well as, I guess, our current clinical challenges such as insulin. And the annual diabetes review will continue, but it's about how and what do I do when I find something abnormal in the diabetes review, rather than just being a wee bit of a tick box procedure. I think another big thing about diabetes at the moment is diabetes creates some of the biggest inequities we have for Māori and Pacific people. And that's for multiple reasons, but now it actually provides the perfect opportunity for us to use not only this new agents, but all of our agents for the treatment of type 2 diabetes and cardiovascular disease, and thinking about how can we do this better to reduce inequities and standardise care across New Zealand. Doesn't matter if you're in Kaitaia or Bluff. So with the guidance, there are overall arching management insulin algorithms. We're trying to get this in a PDF print-friendly form, so you can put this on your wall and just glance at that rather than going onto the website all the time. We're also trying to get on health pathways and to be embedded within practice management systems. It's just a work in progress. There's lots of information on there. I'd encourage you to all have a look, and it links into other current sort of relevant national guidance, such as the weight management guidelines, diabetes and pregnancy, NZTA, MedSafe, for example, and also have Dietitian New Zealand resources in there, so you can print those off and give to patients. Just sort of show you just briefly what the website looks like. You can see there, I guess, all the areas which have in-depth information on, all the way from screening and diagnosis to monitoring, even pre-diabetes. But if you want more information on empagliflozin, you click on non-insulin medications, and it will give you the list there. And then, for example, then you just click on SGLT2 inhibitors, and you'd find everything there in terms of going through for further information. And it's there for everybody. It's there for, it doesn't matter, doctor, nurse, pharmacist, patients will even also be going in on there. It's available to all. So really just finishing for discussion, and I wanted to stress best practice hasn't drastically changed, but this is the perfect opportunity for us to make a difference to all New Zealanders with diabetes and address our inequities. And the big key is working out how we're going to implement this and reduce our own clinical inertia. I'm happy to take any questions. I know I went a long time, sorry, but I'm also happy to go maybe 10 minutes after if just to answer any more questions if there are any. But thank you for listening.
Thank you, Ryan. We've got quite a few questions coming from people, so I guess we should address those first. What do you think?
Yeah, we'll go for it.
Okay, so what is the EGFR range for the SGLT2 inhibitor?
Basically, if you've got anybody over EGFR greater than 30, you can start.
Pardon me?
Anyone with the EGFR greater than 30 mil per minute, you can start.
And stopping?
I probably would stop it if EGFR dropped below 30 mil per minute.
Okay, and thank you. And a question from Brooke. If you start self-funding empagliflozin in a new TDDM, will they not then meet criteria for SA in 3 months' time, as they haven't tried metformin alone for 3 months?
Yeah, it's a good thing. So you would. There's two parts here. One, you still want to meet funding, you still need another glucose-lowering therapy. But for patients which do choose to self-fund, and this is how I see it, they self-fund empagliflozin or dapagliflozin, there is a special authority waiver that you can do if they met the funding criteria at the time. So, for example, I've had lots of patients that have been self-funding dapagliflozin who now can switch over to funded empagliflozin. So there is that waiver for that situation. But I would not. So in all patients, I'd always be encouraging metformin first, either alone or in combination with another agent if you need to get, if you think you need it for glycemic control. It may be empagliflozin if they want to self-fund, or it may be vildagliptin, for example. You may start off with Galvimet.
Thanks. And the next one is, so should we be swapping all our patients on sulfonylureas to SGLT2 inhibitors even if controlled, and how would we do this?
Yeah, well, the one, if they've got renal disease or cardiovascular disease or heart failure, the answer is yes. And you may still need to keep them going on their sulfonylureas for glycemic control. So it'd only be stopping their sulfonylureas if basically you're worried about hypoglycemia. But if you can get them off, that's great, because all of a sudden they may not even need to monitor their glucose levels anymore. So that is, and so for example, if the HbA1c was greater than 75, I wouldn't even bother stopping the sulfonylurea. I'll keep that going, but I'll add it on. But if you're able to get the HbA1c to target, I'll definitely trial stopping the sulfonylurea.
Thank you. Do you know if funding will come for CVD indications without diabetes?
I know that they're trying to get this across. It won't be in the near future, but I know it might well be at some stage, not that far away, that we see it funded for heart failure.
And when you increase ACE inhibitors with e.g. GR45, what is the maximum level potassium you would be worried about?
Yeah, if the potassium's high, then it is limiting. The thing that's really hard is, I guess, that when you check potassium, or when you take any blood in the community, often it sits around, particularly if you're in rural areas, a long time before the courier comes along. So the sample gets hemolyzed, so potassium's high on that. So it is really important that you check the potassium on a non-hemolyzed sample, but you're going to keep increasing the ACE inhibitor until the potassium allows.
Great. Now, can you read me out? Your URL for your website was blocked by your picture. And
oh, sorry. Yeah, it's if you go to www.t2dm. T2dm.
Yeah.
.NZSSD.
.NZSSD.
.org.
.nz. Okay, I'm just posting that on the chat because it will help people.
Oh, that'd be great. No, thanks for that.
Okay. Is empagliflozin?
Yeah, I know, it's a tongue twister.
Empagliflozin. If so, why is it not funded?
I guess it's pharmacogone for one agent. In fact, if you look at the studies, empagliflozin's probably got a better reduction in cardiovascular disease than dapagliflozin. So I think they chose the right one. But when you are switching patients, dapagliflozin's only one dose at 10 milligrams daily. You're going to switch them over to empagliflozin at 10 milligrams daily. So it's like for like. I'd start off on the 10 before jumping to the 25.
Cool. And was there SA funding for empagliflozin for HbA1cs less than 53, did you say?
No, there's not. HbA1c has to be above 53. But if it's less than 53, that's the group I'll be talking about, whether they can self-fund, because they will still benefit.
All right. Well, thank you very much.
No, thank you to all. I hope you have a good rest of your day.
And thank you, everybody, for joining us today.